Okay, so welcome to the Hammersmith Hospital. We've got Carla, our interventional fellow. We've got Russell, who's doing our TOE magnificently. This would not be possible without Fiona, who's our anaesthetist. And we've got Paula from Edwards preparing the valve for us. And we have a case of mitral valve-in-valve TAVI, really as an emergency. Came in with heart failure, BNP of 12,000. That's been cleared up. If you look at the 3D echo, the mitral valve's hardly moving. And it's amazing that she's not even sicker than she is. So I think we did an emergency MDT. We've agreed that this will be a valve-in-valve TAVI. If you just look at the pictures there, we can see the catheter coming across the septum. It's now the safari wire going through the middle of the septum. And you can see that it's going through the mitral valve, and the mitral valve has very little movement in it. The other wire is a safety wire, which is going into the left upper pulmonary vein. If we go through the X-ray pictures, first stop is to line up where we're at. And so we can see that with an areocranial, the mitral valve is aligned. It looks like a perimount type valve. And so we can also see the aortic valve, but that's not what we're focusing on. You can see the biventricular pacemaker. So we're then trying to find a view that gives us the LVOT. This is RAO caudal, showing that the two valves are obviously close to each other, but on CT and echo, hopefully we'll be able to demonstrate we haven't impinged the LVOT. Okay, we're then getting the LAO view of the aortic valve, and we've got an LAO caudal view of the mitral valve in as much circle as we can. So we're now got a wire with a sheath going up into the SVC, avoiding the pacing wires. We've gone to LAO, and then we've got a BRK needle coming up. The BRK needle is then used on transeptal puncture. So you can see that we've got a dent in the septum, pretty much mid-septum, both anterior superior and anterior posterior. And so I think a safe place for the thin part of the fossa. And you can see we are trying to push the needle through. We actually needed diathermy after the needle had gone through to actually push with a stylet, and then a quick twist to actually get the sheath through. Okay, so what we were trying to do is look at the appendage as we now try and push a wire, and you can see the wire had not gone into the appendage. So the sheath goes up into the left upper pulmonary vein on an 032 wire, placed a stiff Amplatzer wire as a buddy wire into the vein. Want to see that again? There we go. Okay, so we've then removed the sheath. We have two wires across the septum next, and we can see we've done a balloon septostomy. Our largest Mustang balloon is 12, therefore we've taken a 12. So we're now bringing an Agilis sheath up. Okay, so we're now trying to cross, and we have just crossed using the Agilis sheath and just a pigtail catheter into the left ventricle. Okay, so now we can see that we have the catheter across on 3D. And just before we put the stiff wire up, I crossed the aortic valve with an AL1 catheter and straight wire to make sure I have a safety pigtail in the left ventricle. And we've now got a safari wire, and you can see that I've changed the sheath to the E sheath. So where we're now at is that we have an safari wire, which is through the mitral valve with an E sheath in the IVC. We'll see the E sheath coming up. And actually, I've taken the dilator of the E sheath through to see how something reasonably stiff would traverse the septum and the mitral valve. And actually, it was quite comforting in this occasion that you can see that the introducer straightens itself out. It moves through the valve, and you can see that as it moves through the valve, everything seems to straighten, and that's as far as we can go with the sheath. So I'm hopeful that the valve will do the same. And that's where we're going to be to deploy the valve, making sure that our valve doesn't poke beyond the posts, which are poking into the left ventricle. Okay, 29 plus 2 is perfect. We like to flare a little bit if we can. Okay, so now it's very important to have Edwards pointing downwards here. So we're going to rotate everything. So Edwards is down. Okay, so that way the bend that we're going to put on is going to be helpful rather than unhelpful. We're going to bring the sheath backwards while I advance the balloon a tiny bit further. Keep on going. Hold there. Okay, so I think that looks fine. We can now advance the sheath up and the balloon. So let's take the balloon up. So I'm going to take the whole contraption up, and now it's going to be the valve that's going through. And at the start, I don't really give any tension or torque. That's now trying to get the valve through. The nose cone is through. So you can see on 3D, the bulk of the valve is actually across. So now we're going to hold the wire still, and hopefully this is going to pop through. Okay? So there's a little bit of the pusher just stuck So that has popped through. Right, so I think we're in a good position. So we're going to start our inflation, slow inflation, nice and slow. Positioning it again, I'm pushing in a little bit, tiny bit more, hold there. So we can still probably move it a little bit. I'm pushing it in now, okay? So I'm pushing the wire in a bit, okay? So I'm pushing it inwards. It's beginning to inflate. Now another mill. It's straightening. Okay, now it's probably a bit too low. So I'm pulling it back into the left atrium, pushing the wire. I'm pushing the wire. Go again, another mill. Okay, go again, another mill. Go again, another mill. So go and another mill. Yeah, another mill. Yeah, I know. Okay, now slowly finish it off. That's it. Keep on going. Keep on going. Lock it. Finish it off. Lock it. Finish it off. Lock it. Is it empty? Okay, deflate. Deflate fully. Okay, deflate fully. Okay, then lock it on deflation. Lock it on deflation. So we're now going to bring this back. Okay, so we're taking everything out. The valve looks as high it could possibly be. My question is it flared? So let's take a proper picture. I think it looks flared at the bottom. So the great news is that the LVOT gradient hasn't got worse. Okay, so we can see that, you know, it's well landed. The aortic valve, the LVOT, you would hope was fine, because most of the LVOT is clearly behind the plane. That's where the pigtail is, and that's where we've got the gradient. So the mean is 4. It was 9. Okay, that it doesn't look absolutely normal. Okay. Okay. So I don't see a lot of turbulence in the left ventricular outflow tract, and so I think there's a lot of this which is just the valve. Okay, so that velocity hasn't really changed. I think that's really convincing. So there's an LVOT with really very little gradient, and then move into the valve, and then the gradients are going to start shooting up. Here we go. With that, I'm going to say that this looks like a successful case. Thanks for joining us at the Hammersmith, and we'll see you again soon.